Okay, this section we are calling County Challenges and Solutions. We have two counties here to talk about the challenges they face, some of the solutions they found, and it's probably every county in the room could stand up and give you a different version of what they're going to talk about. And then tomorrow we'll be looking at providers and we'll be looking at health plans as well. So I'm going to start with Dr. Marvin Southard from Los Angeles County, and then we'll hear from Mary Hale from Orange County. Since we happen to be in Orange County, that seems appropriate. So, Marv?
Okay. So it's a pleasure to be here. I think maybe I'll have more challenges than solutions for you, but the challenges that we'll be facing are the ones that are indicated on the next slide. We're going to try to work this out. Yeah. So these are our goals for the implementation of the Affordable Care Act and its challenges. We have to ensure service capacity and access, and that is really complicated for us because it's not just access for more clients, which is part of the thing, but access for more clients with defined timelines that we're coming to understand what those defined timelines mean. We need to enroll the clients that we have in the benefits that they are entitled to. And that is a part of our overall fiscal challenge, because if we get that right, we'll have money to do the first thing. If we don't get that right, then we will be challenged to be able to make our access goals. One of the biggest challenge, which I believe to be the challenge that faces the whole healthcare system, is how specialty care and primary care are properly integrated. And that issue is raised even to a higher level when what we're talking about integrating is mental health treatment, substance abuse treatment, and primary care. And in Los Angeles, I'll speak a little bit about how we're hoping to do that using the concept of health neighborhoods. The health neighborhoods are our vision for both integrating care and empowering communities to care for their own. We won't be able to do that unless we enhance our workforce in a variety of ways and also to use technology. Next slide. So the access has been, this is our problem. The blue at the bottom in this slide indicates the number of MCE clients, Medicaid expansion clients, that are coming in per month. These are the number of new clients each month. So we get in our system about 7,000 new clients a month. And the problem that you see here is that the percentage of Medi-Cal expansion has remained constant. It hasn't grown to the degree that we thought it would. And another challenge is that the traditional Medicaid program has actually grown more than we thought it would. So the woodwork phenomenon, which we had thought was a possibility, is in fact an actuality. We're having more traditional Medicaid people, which is all good, except we have to identify the local match. Next slide, please. So this slide indicates the total number of clients seen in our system, and it presents a similar picture. The Medicaid expansion of our total population has remained stable, and we're trying to figure out why that is, because what we hoped to see was that over time we would convert our MHSA or our indigent populations into Medicaid expansion populations, and that bottom percentage would increase over time. It has not increased. We think as much as we thought it should, and so we're taking steps, and one of our challenges, at least within the directly operated components, we're going to be we have taken steps to identify within our own directly operated component of our system those clients who ought to be eligible and asking the program heads why they are not enrolled. And so we've brought in eligibility experts from our Department of Social Services as well as community agencies to help us with that task of turning people or getting people enrolled who ought to be enrolled. Because as I said earlier, the revenue from doing that will allow us to meet the goals that we have for access. Next slide, please. So this just gives you the demographics of what our Medicaid expansion population looks like. It is not very much different from our current treatment population, so, but I thought you might have an interest in that. And then this next slide indicates the revenue that we have coming in from Medicaid expansion from January to June of this year in categories. And the one that is surprising, to me at least, is the amount of fee-for-service inpatient revenue that is reflected here. And it's not so much the amount of the revenue, is the revenue for inpatient compared to the revenue for outpatient. So obviously our inpatient revenue generally under Medicaid is much larger than our inpatient revenue. So one of the things we're trying to investigate is what's that about? Because as of this moment, we don't know exactly what that's about. But one of the challenges for us will be to examine the treatment data and the revenue data to see how that changes the way we implement our programs. Next slide. So one of the things that we have had responsibility for in the plan is as we accept referrals from the health plans for urgent appointments, they needed to be done within a certain amount of time. And so this is the good news. Well, the two pieces of good news. There have not been that many referrals so far. They're right now they're around 60 a month, but we've been able to meet our goals almost completely. So the majority of clients, as you can see from the chart, are seen within 3 days. So urgent appointments referred by the health plans are able to meet the access requirements of under a week in almost all circumstances. So that's the good side. Right now, the volumes are low, and we've made our agencies in our community agencies as well as a directly operated program know that these are priorities because it's a requirement. So far we're meeting it. The problem will be, will we be able to continue to meet this as things develop? So we're trying, as I mentioned earlier, next slide please, we're trying to use the access grants and community agencies to enroll whoever we can by doing in-reach for clients who are already being served. But also we're doing outreach in the community, so we're doing enrollment, particularly as a part of our efforts to outreach to faith communities, because one of the things that we've done in Los Angeles is to make faith communities our partners in much that we do, but especially in outreach activities. And then we're playing around trying to push the limits with presumptive eligibility and getting the hospitals to allow us to use that authority where we can. So we're working with county council to see how far we can get our staff to be considered hospital staff or have hospital staff come to our urgent cares so that they can enroll people in that context. But before we do anything, we check with county council so that we don't get in long-lasting trouble. Next slide. So then I was talking about the health neighborhoods. Health neighborhoods are the concept I think I have spoken to you about before, and one that for which the community excitement has grown quite a bit. The health neighborhoods exist at two levels. At one level, it's the consortium between the health, mental health, and substance abuse provider that serves a particular geography with the idea that they share information, labs, diagnoses, support and outreach strategies so that they can work together rather than against each other in terms of medications and so forth, and to be able to provide a vehicle for care coordination. But if we did that, we would believe that that was only a part of the picture, because the bigger contribution to wellness and health care is not access to quality care, though that's a part of the picture. The bigger part of the picture is the access to community support in a variety of ways. And so we are expecting the health neighborhood to be where that coalition of healthcare providers for a particular community reaches out to the community and asks the community, what do you want us to do as a health consortium to help you address the social determinants of health outcomes as they exist in your community? Further, we're trying to do this not from scratch, but to build on existing community organization efforts, because a good community organization effort takes 3 years to get off the ground, and we don't have that amount of time. So whenever we're doing this, we're trying to build on existing community infrastructure, such as those that are created in our county, at least by the California Endowment, by First 5 LA, the First 5 organizations, as well as some federal empowerment grants. So rather than start from scratch, we'll go to those communities, look at their strategic plans, find out what they are planning to do, and find some symmetry between their plans and what a health consortium could contribute to the social determinants. So good examples might be in a community that is facing a lot of violence. It could be that we train the community and focus on issues of response to trauma. So community teams can respond to a community when there's a shooting. And that might be teams in the faith community or with the hospital community, and we would try to work that together. But that's merely an example. I'm not saying we're going to do that, because the process is really asking the community. And we believe the power of this comes at two levels. At one level, the power comes because whatever the community chooses to work on will get a little bit better. But even more than that, because the community working together itself breeds better health and mental health. So that's kind of the strategy of the health neighborhoods that we're trying to employ. Next slide, please. And this is another indicator of why. On this slide, you'll see the percentages that contribute to a healthy outcome, and you'll see that the quality clinical services, access to them contributes 20%. Personal health practices like not smoking, not controlled drinking, exercise, 30%. Not living in a polluted place, 10%. But the biggest contribution to health is actually the social environment of where you live. 40% comes from that. So that's the rationale for using the health neighborhoods as a approach to this integration issue. So when I'm giving this talk in LA, I say, if you lived in LA and you could only ask for one piece of information to predict your health status and how long you're going to live, what would that piece of information be? And it wouldn't be your genetics, it wouldn't be your income, it would be your zip code, right. And so, and in LA, the disparity between the healthiest and the least healthy zip code is a longevity expectation difference of 17 years. So most times I say that, that's a pretty significant importance of why we need to focus on community. So next slide, please. Talks about the service delivery model we imagine for the health neighborhoods, improving access, improving the effectiveness of the services that we provide, and improving the client experience. Because with the social support, we believe the clients will have a better experience as well. Oh, okay. Okay, we got ahead of ourselves. So either there was a slide skipped or I went too fast. So this is the process of where we are in, no, go back again. One more. Okay, stay there. That's good enough. This is where we are. So as you can see, some of the activities that we're trying to do to implement the health neighborhoods, we've already completed. Some of them are in process. Some of them are yet to be done. We had a meeting yesterday with UCLA, RAND, and a bunch of community leaders in South LA, because in November we'll be submitting for a multi-million-dollar federal PCORI grant to support the implementation of health neighborhoods, and I think they're going to look at 29 communities for this grant process. If we get that, that will accelerate the process, but if we don't get it, we're going to move forward in any case along this stairway. So the first 5 places we're going to start, and any of you who work for counties know why we're choosing 5 places, with the exception of San Francisco. I guess they would be doing it in 15 neighborhoods, but we just have 5. And they're Lancaster, Pacoima, Boyle Heights, Watts Willowbrook, and Central Long Beach. Each of these places already have a community organization effort in place that we're going to build on. In each of them, a consortium of health, mental health, and substance abuse providers have already been formed. And so it's a matter of linking those to the community effort, deciding on the health disparity, and moving forward. Next slide. Okay, next slide. These are the technological things that we're trying to use. We're implementing an electronic health record. We're working with our health plans to use e-consult as a way of providing consultation on psychiatric issues to the primary care physicians. We have a pretty robust telepsychiatry program already in place. And we're experimenting in using teletherapy. We're going to put in an RFP, and we're thinking at this point that we'll make it as an organizational provider practice. So we'll do something in the fee-for-service mode, but we have to, again, get permission from county council and so forth to see if that may work out. Next one. Workforce development, we're training everybody in individual CBT, Health 101. Health 101 is training our mental health workforce on the basic health issues that they may need to be able to know how to track with their clients. We have a more robust thing, the Foundations of Behavioral Medicine, which is focused on psychologists and what they may be able to do as a specialty practice within our system. And the mental health integration program, the MHIP program, the adaptation of the impact model that we used for the 1115 waiver, we're expanding the training for that. So the next slide. And then we're also expanding the workforce and trying to do that in training the classifications that we need and the peers that we need for this system, because we believe that particularly in the arena of the care coordination, we have a great opportunity to be inclusive for people with lived experience as coaches and trainers for other people with lived experience. Next slide. Yes, so we're also educating the community, and we're doing a lot with mental health first aid and emotional CPR. We have a clergy academy where we're training literally hundreds of church leaders, church, synagogue, imams, Buddhist monks on mental health first aid and emotional CPR as one of the parts of our Clergy Academy program. It's been extremely successful and engaging. And for example, as we trained the Buddhist clergy, they wanted also additional training for their youth. So we started some youth training, and then the youth having been trained, the parents wanted to be trained. So it was really a significant mental health training impact with the Buddhist community in LA. So I think I've talked enough. And as you can tell, there's a lot going on, and we have many things that we are tracking on the progress of these things, and I would welcome some dialogue on them if we end up having enough time. So, thank you.
Thank you, Marv. Alice, I think this might be what you were looking for. So, hi, good afternoon. I am Mary Hale. I am the Behavioral Health Director here in Orange County, so I do want to take, okay, so I'm going to, okay, great, I'm going to do it myself. Okay, I'll try to stay ahead of where I am. I'm the Behavioral Health Director in Orange County, so I do want to say welcome to Orange County. I'm really pleased that CIBHS has selected Orange County as their location for the fall policy forum. I apologize that it is so hot. You know, I'm going to do something about that tomorrow, and it's going to be a whole lot cooler, both tomorrow and Friday, so stick around. I promise it will be cooler. But the disadvantage of being local is I don't get to stay here in this nice hotel. You know, I have to go home tonight and tomorrow, but I hope all of you enjoy every single bit of this forum, because I know Sandra and her team have done a really good job of putting it together. I do want to mention, you know, you're here at the home of the happiest place on earth. So I and many of the behavioral health team of Orange County are here. So if any of you need information on that or any of the other things about Orange County, in addition to being staff at Orange County Behavioral Health, we will also be tour guides. So that's my second role. I had wanted to say, because I thought I was going before Dr. Southard, I was going to say I was going to be the opening act. I didn't get to be that. That was going to be my third and most significant role. I don't know how I feel about following him. He's always so good. I love to participate with him on committees because he always has such good information. Usually when I follow him, I just go, whatever he said. And really, with regard to integration, much of what Marv presented to you is really the same as what we're probably doing in many of our counties. On a smaller scale, of course, but a lot of it is the same. The neighborhood homes, we are not there in Orange County, but lots of the same things are what we're doing. I know I'm the last presenter for today. I'm going to be brief. I'm going to actually be very simple. When we talk about healthcare integration, I could have talked about mental health and substance use, and certainly there are lots of challenges. And in Orange County, we've been working on this for so many years. We think we have a plan for what to do. We think we have some solutions, but I chose to not talk about that. I know we're reminded today in the welcoming talks, and Al Sinella talked about even some of the mergers that have occurred, that we can't forget to keep focusing on some of the issues that have been long-standing, whether it's trust or actual integration of those two. But I think we're in Orange County on the right track with that, but what I'm going to focus on is physical health care and behavioral health in the presentation. And the objectives that I'd like to achieve today are really to identify what key challenges we've identified that impact physical health care integration here in Orange County, specifically give you some solutions that we've identified for those challenges, and then to illustrate one of the programs that we've done here in Orange County that does integrate both, well, not really both, all three, mental health, substance use, and physical health care in our county. So the key challenges, and it's not just these three, but these are some of the main ones that we've seen, and they're probably not a surprise to you. Information and data sharing, really a big one. The Affordable Care Act, and Marv talked about the whole issue of accessing Medi-Cal. It's been an important issue. And at the provider level, there have been challenges, both with primary care. We know the benefits, and I actually am glad not just to follow Dr. Southard, but Christopher with SAMHSA. He really laid out nicely what the benefits, the advantages, the reasons for integration across behavioral health and physical health care are. But yet, we know at primary care that there can be that, not even just the perception, but those initial steps of integration can be burdensome. And at behavioral health, that coordination with primary care will take additional effort and time. Now, we know that in the long run, it'll make things better, but it can be a challenge. That specific program that I wanted to talk to you about is called Integrated Community Services. And what this is, ICS, we have to have an acronym, is one of our Round 1 innovations projects. It was actually the first one that we started, so we've now it's been up and running for over 3 years. And what we were looking at was the effectiveness of integrating primary and behavioral health integration both at the community clinic and at the behavioral health clinic. So what we call it, we have the ICS community home, where we have behavioral health staff in the community health clinic. So we have FQHCs where we've embedded a psychiatrist, professional mental health staff, as well as individuals living with mental health issues or family members, peer staff. And then at the ICS county home, we have primary medical staff, a primary care physician, a nurse, and again, we have those peer staff, individuals in recovery or family members. So we were looking at that bi-directional integration and wanted to study how it worked. The actual learning question that we posed with our innovations project was really whether or not having the peer staff would make a difference. And as we talk about solutions, we really are finding that they do play a role in helping us with that. So getting into those challenges. So information and data sharing. Let me make sure I follow this. Clearly, I imagine everyone in this room knows how important it is to be able to share personal health information to ensure coordination of care and to assist in overall patient management. We have to be able to do that on the patient level. We also need aggregate data to help us with community needs and to reduce those overall risks. So just identifying it as something that is important. The challenge, you probably all also know this, has been the compliance and regulatory requirements. What I wanted to talk about is in behavioral health, we often think that the biggest barrier is 42 CFR or perhaps HIPAA. And as we've gotten more into this, what we think is really the biggest challenge. I won't say that it's not 42 CFR. That certainly is a big challenge, but it's not HIPAA. It's those multiple other state requirements, and further, it's the interpretation of all of those multiple requirements. And the fact that at each county, it depends on your county council, it depends on your compliance officer and how they interpret them. And as we try to integrate behavioral health and physical health, oftentimes on the mental health plan side of things, or the substance use side, sometimes the health plans think, well, you have the statute, you have the regulation, it should just be easy. Isn't it just the same across all 58 counties? No, it's not. So it has been quite a challenge for us to get those agreements in place, those MOUs in place. And so a possible solution is to rework those statutes to reflect what would really work best for us. And certainly when we come back to 42 CFR, there are many of us in the room that have been talking about that for years and years and years. And I think when some of us, myself included, and certainly our medical director and other members of our management team, when we started to see the various state requirements, honestly, it was a surprise to us. I don't think we realized how many different state requirements there were that played a role in limiting our data sharing ability. So there's a lot of work to be done there. And that solution that I suggested is also not an easy solution, and it's not one that's been done yet. Another challenge with regard to information and data sharing is that varying data systems between the entities can hinder accessing information and data. Not every system has the same type of system themselves. The large entities may have great data systems. They may have EHRs. They may be well on their way to being able to share information with one another if they have the right consents or the right connectiveness. Other entities, some of our mom and pop organizations, are nowhere near to being able to do that. So you've got different levels. And one of our solutions with our ICS program has been to create a patient data registry. It's not perfect. You still have to have individual consents for sharing the information, but the registry allowed us to have a web-based system where we had all of the data elements that we wanted to share. We had, at our county, we had compliance, IT, the health, the community health clinics, everyone get on board, and we were able to get around a lot of the problems, because we do have mom and pop entities that don't have electronic health records. We don't have an across-the-board electronic health record yet. We're on our way. We've started to go live, but it was a way to help. And so looking at things other than a full electronic health record, things other than changing statute, that was something that we were able to do that helped us. But again, continues to be a challenge. Since the Affordable Care Act, accessing Medi-Cal, there have been some challenges, and do want to say what a great thing that so many more people are able to get Medi-Cal, to be eligible for Medi-Cal. But I think throughout the state, you're all aware of the backlog of applications. Certainly for existing members, there's a backlog there's a continuing stream of new applicants. I know Marv talked about he's got just a steady stream. I don't have that data for Orange County. I don't know if we've stayed steady yet. We haven't been able to get that. But we're concerned just with folks being able to get eligibilized. And we're worried about the renewal. What's going to happen with that when it's time for their renewals. With ICS, one of the things that has really helped with getting folks even to fill out the applications and to do that follow-through have been those peer staff. Really just getting someone to stay with them to help. When we first started the ICS program, and each county is different, and our county had different reasons for doing it, but we only opened the program to individuals that either already had Medi-Cal, who were in the LIP program, or who were eligible for it. So you would imagine that really everyone in the program should have then, on January 1, should have been able to go right into the program. And so having those peer staff following up and working with them has proven to be very, very helpful. At the provider level, some of the challenges are, as it talked about, integration being burdensome. Concerns from primary care that they just don't have the right skills, they don't have the right competency to do the screening and the assessment that's required. They need more time, they need more resources. From behavioral health, again, coordination takes effort and time. Doing shared care planning, how are you going to get around that? And that the reconciliation of providers outside of behavioral health, it was new, it was different. And navigating a system that's so large, in and of itself is a challenge. We're very large. Just in our county-operated system, we have over 1,000 employees. When you add in the health plan, when you add in community-based health clinics, you're just adding in so many more people. And while, again, you've got all of the benefits, it's just seen as burdensome. The solution that we came up with from ICS was really, and I know Dr. Southard, Marv talked a lot about this, about cross-training. Cross-training not just the behavioral health staff, but also the medical staff. Providing consultation, having the behavioral health psychiatrist available to consult with the primary care doctors really made them feel much more comfortable. Collaborating on those treatment team meetings, even though it seemed like a lot more coordination, over time, and it didn't take a lot of time, after, just a couple of months, it really gave people a lot more comfort to know that they were working together and there was going to be that help. One of the things that we did on that issue of screening and assessment, we worked with UCI to modify SBIRT and used that as a brief tool just to do an initial screening. And we were looking for alcohol, illicit drugs, domestic violence, as well as anxiety and depression. And so had that modified tool to look at all of those was really helpful. We actually used that tool across all of our innovations projects, and it's been very helpful, but we definitely use it in ICS, and all of the staff are very comfortable now with doing that. We've been talking about no wrong door access for a long time. We continued to focus on that, certainly with ICS. And of course, having the expanded mental health benefits as of January 1 is something that is good. We've got to work out the issues around our MOU. We are a county that still does not have that. We don't have it signed. We've worked out the issues, but it's taken us longer than we thought it would. We, like everyone, was supposed to have it in place by June 30th. It's not signed yet, but we're getting much closer. But that bi-directional movement between the health plan and the mental health plan as recovery process progresses is a good thing. And that's actually the end of the PowerPoint. What my hope is that those solutions that we came up with will actually be helpful to some of the other counties. We have certainly seen success with our program, both on the physical health side and the behavioral health side, and we are strong believers that physical health care and behavioral health care integration works. So, thank you.
Well, Mary, I'm certainly relieved you're going to fix the temperature for us tomorrow. I grew up down here right next door in Huntington Beach, and I can guarantee you never, ever did I experience it this hot. This is really unusual, but it'll be fixed, right? Good. Fabulous.